Very good morning, and thank you so much to Shroff sir for conducting this wonderful course. And I think all of us will encounter this situation either in the early post-operative period or now, as more and more of us are seeing in the late post-operative period, few years after the surgery. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. And like we said, this decentration can be early or it can be late in the late postoperative period after a few months or after a few years when the patient's present to us. There have been several causes that have been attributed for these dislocations or decentrations to occur. These are the high risk patients, patients with pseudo exfoliation who have loose zonules, previous vitreoretinal surgeries where some zonules may have been lost, homocystinuria, retinitis pigmentosa are known to have get lot of capsular fibrosis and therefore decentrations, and any other reason for capsular fibrosis like inflammation. The first thing, as a colleague or when we see the patient for the first time, is that when we look through the slit lamp, our reaction or our body language is something that the relatives are watching. So be very, very careful on how you are reacting, how you are looking, how your face is changing, how your brows are changing, whether you are smiling, not smiling, if your colleague is sitting next to you, if you have trainees around you, how you are talking to them. So first thing we want to make sure is that our body language is very positive. So one thing I always learned was while I was training was that whatever the complication, look for the positive part. So I remember my teacher who would probably have, say the patient may have aphakia, and he would look at the slit lamp and he would tell us, that's a beautiful incision that has been done, what a lovely surgery that has been performed. So the first thing we want to do is reassure the patient that the primary surgery has been done well. Never say that there is some problem in the surgery or some words, although you may not want to mean to criticize your colleague, but sometimes certain words are picked up by the patient and then they are taken out of context in the long run. So always the first thing that you must say is the surgery has gone off beautifully. It's been done very well, and I wish all of us could be performing at the same standard all the time, all the in all cases. The second trick that we find useful in counseling is that, like we have different structures in the body, we have a natural support inside the eye on which the cataract rests. And our entire aim of surgery, or the entire the way we operate, is that we remove this cataractous lens from this natural support and replace an artificial lens in this natural support. Now, unfortunately, to some eyes, in some eyes, once we open the bag, once we open this natural support, we find that this support is somehow weak. And then next question the patients may ask you, but could this not have been detected pre-operatively? Because you never told me that this can occur pre-operatively. So you can say, okay, unfortunately, these are some of the things that we realize only after going inside and after opening the eye. We can sometimes find out that the support on which we are supposed to do the surgery and place the intraocular lens, which by the way works very well in 99 out of 100 eyes, but in 1 in 100, for no good or bad reason, this support is not strong enough that it can maintain the intraocular lens. What I like to give the example is, I say that sometimes when you go to a hotel or a resort, you have a hammock or a swing, threaded swing between two coconut trees that is tried. Sometimes it comes off from one side. So similarly, it is something similar to that. And there is no specific cause in most of the cases that you can attribute to. So patients will ask, was it because of surgery? Could it have been because of this, that, etc.? So unless you have seen the patient before, unless you know there was a specific reason like a black cataract or a traumatic cataract or something, don't try and give a reason for everything. So I always like to say that there are some things in medicine which we as doctors are unable to explain why you ended up in 1 out of 100, but it's a known thing that this can occur. It's not something which is so rare that we don't see it at all. So try and first of all reassure and counsel the patient that the primary surgeon has done everything that was possibly to be done scientifically in such an eye or in such a situation. Then slowly, once you start doing that, then you have to start counseling, because now you also have to treat him. So then slowly put in the word that although this is something that we don't see often, or this is something that is unexpected, unfortunately this may require a surgical management, and that surgical management could also involve some difficulties, and may also require teamwork, because it varies from case to case what the decentration, how much is it, whether there is vitreous, whether there is glaucoma, whether there's corneal decompensation occurring with it. So you try and reassure them that yes, we are trying to find a solution for it, but this, because like you've had a rare thing which is not so commonly occur. We will need a team of, say, retina surgeon along with me, or glaucoma surgeon, or cornea, which we may need to work together to try and get you back to where we would want to get you in the first place. Also counsel them that now this surgery is going to be different, because eventually, however much you may have counseled, it is the person who operates last who's going to get the signature for everything. So he may have undergone a topical anesthesia surgery, and now suddenly, then when you give a peribulbar anesthesia, or you may end up having to take sutures for good scientific reasons, patch for a day or so, they may feel that this is something odd or something different. So forewarn them that now, because we need to reconstruct a lot of other things, this will require peribulbar. You may have patch. Your eye may be uncomfortable for the first few days compared to your friends or relatives who undergone cataract surgery, and this will require long time for visual recovery to occur with frequent follow-ups. And also forewarn them that such eyes where the natural support of the cataract was weak, in such eyes, like your natural support of cataract moved away, the retina can also move away in such eyes. So retinal detachment or corneal decompensation on glaucoma, but still in the end reassure them that most of such eyes do well eventually in the long run. So I think uh, first thing is reassure and make sure that you never give any signal, particularly from your body language, that you could have done something differently and this complication would not have occurred. You don't know how the patient behaved under the microscope. You don't know if he moved at the wrong time, so on and so forth. So try and make sure that we reassure them as much as possible. So I would like to end my presentation at this point. Thank you so much. So there are two, three types of cases that I'll be sharing. This was a 60-year-old male, right eye multifocal lens done elsewhere. Very, very bitter, very, very unhappy with this quality of vision. Although acuity was reasonably good, but and when we wanted to find out what is the cause for his unhappiness, and the cause was obvious on dilatation. That uh, the lens was out of the bag. As you can see here, there's fusion in one half of the area of the anterior and posterior capsular axis, and the optic is in the sulcus with lot of pigments and other things that you can see. When we did the UBM, this is what we found, that one haptic was in the bag, and one haptic and the IOL is actually tilted and rubbing against the iris, which is probably one of the major reasons for his visual discomfort. And if you see here on the eye trace, these are the internal aberrations. So you can see there's so many internal aberrations being created because of that tilted IOL, and not to forget the uveitis and other things that are occurring because of the single piece IOL. And this constant rubbing is going to cause a lot of irritation, and this tilted IOL leads to lot of aberrations with the eye passing with the light passing through the IOL. What we did was, in this case, we could fortunately open up the because it was relatively fresh, we could open up the synechia between the anterior and the posterior capsular axis. The axis was actually nice and intact. It's just probably that it was missed out during the IOL positioning, that part of it was not inside the bag, and we could redial this IOL back into the capsular bag, and this is how it looks post-operatively, with a good outcome, and very little residual error, and the inflammation and the quality of vision related symptoms dropped significantly. Coming to the second type of decentered IOLs that we are encountering now more and more, the late decentration or dislocation of IOLs of patients operated 8, 10, 12 years back with perfect surgery. So there are two types of these late decentrations. One is spontaneous rupture of the posterior capsule with intact zonules. So everything else is normal. Somehow the posterior capsule gives way and the IOL decenters through that, which has been now described by Dr. Sam Maskett as the dead back syndrome, published last year in JCRS. And this is what I typically mean. A perfectly well done surgery by you many years back, perfect anterior capsular axis, IOL in the back, but somehow after many years this posterior capsule gives way and the IOL tends to decenter to that. Another example of late presentation of this situation, as you can see, a very nice good capsular axis, no fibrosis, no contracture, but the posterior capsule just gives way. Another example of the same multifocal IOL done by us just 10 years back, good capsular axis, posterior capsule gives way and the IOL goes back. And the second kind of decentration is the dislocation of the bag IOL complex completely, which means this is a kind of zonulopathy, that the zonular complex gets damaged or deranged and it comes off from one side and therefore it decenters. So coming to a case of a 54-year-old male who had traumatic cataract with traumatic mydriasis. We operated him for cataract with a double aniridia ring in 2012. And 5 years after the primary surgery, he presented to us again with this, which means that this IOL bag complex is started to dislocate inferiorly, as can be seen in the retroillumination. And we thought two aniridia rings means two CTRs in the bag. At that point of time, intraoperatively, we thought it was enough for this eye, as it was a traumatic, so no progressive zonulopathy. So here it would have been very difficult to remove this entire complex with these large aniridia rings in place. So our first plan was to try and open up this bag, and if we can do that, we can try and fixate this same bag to the sclera. So here we are using a 26 gauge needle across, as it's been 5 years since we operated first. Fortunately, due to the aniridia rings, the fibrosis isn't so severe because aniridia rings are typically made up of PMMA, and we were able to create a reasonable gap between the anterior capsular opening, and through that we decided to pass in a double 2-point fixation Sioni ring, which means we are planning to fixate it at 2 points in the sclera, on this side and on this side. And we have our preference now for sutured fixation is the Gore-Tex suture, which is non-biodegradable and used by cardiothoracic surgeons in cardiac bypass surgeries. And you can either railroad them or you can just cut off the needles and pull it through very nice micro incision retinal vitreoretinal forceps. And once that is done, you tie it on both sides and put it under the flap. And this is how the patient looked at 1 week. Centered IOL, you can see both the eyelets of the Sioni along with the Gore-Tex suture. And this is how he's doing well post-operatively ever since. Another case of the IOL bag dislocation, and when it's beyond a certain point, the only treatment is exchange of this IOL. That is, you need to remove this IOL along with the capsular bag and so do some sort of IOL fixation. Our preference is some sorts of scleral fixation. Initial preference was with transscleral sutured IOLs with Gore-Tex, and now our preferred technique is the Yamane intrascleral fixation. But the major thing that we need to take care of is good vitrectomy, and therefore working with a retinal colleague is of paramount importance. As you can see here, this is a dead back syndrome. The capsular axis is intact, but the IOL is dislocated. You need to do a good marking 180 degrees apart and 2 millimeters from the limbus. And if you have access to digital marking, you can do it with the Varion as well, but it doesn't matter. You can easily use the Mendes ring and 2 millimeters from the limbus on either side where you'll be passing the needle tracks. Before you actually handle the IOL or pull out the IOL, it's very important that you remove and cut the vitreous adhesions that are there around the IOL, because any pull on the vitreous adhesions will lead to a lot of vitreoretinal traction and therefore possibly retinal breaks occurring. Once that is done, we sort of either you can cut the IOL or you can just enlarge the incision a little bit, as we did in this case. suture the rest of the wound, and now the time for the good vitrectomy comes. And it's very important that you remove the sommering rings as well, because this will not only sometimes resist your intrascleral fixation, but because now this is an open area, sometimes if after few years the sommering rings gets dislodged into the vitreous cavity or they come forward, it can cause severe inflammation. So make sure that you remove the entire capsular bag complex from all sides. Like here, we found that we needed another incision to go and catch the capsular bag, and make sure that you remove the entire capsular bag complex along with whatever sommering rings are there for good postoperative outcome. After haptics. PVDF haptics are ideal for Yamani fixation. The PMMA IOLs are not, they tend to kink very easily. And therefore, this is the matrix IOL distributed by Epsilon in India, no financial interest. And with 30 gauge thin wall needles, you actually use these forceps to first thread in one end of the IOL into this 30 gauge needle. You can do the traditional Yamani technique of double needle. That means you put both needles in together and pull them out together. We find that little more technically challenging. Therefore, we tend to thread one end of the haptic completely, and once that is done, we pull out that needle and we cauterize it with a normal heat cautery. And then the other needle, we bring it out to the incision. We find that this modification makes it much more user friendly rather than manipulating too much intraocularly. And once that is done, you pull out that needle also and do a thermal cautery and make a bulb. And uh, it's very important that peripheral retinal examination is done. Quite often breaks are detected and the retinal surgeons laser them intraoperatively, and this is how these patients look post-operatively. It's almost sometimes very difficult to say whether it's an in the bag IOL or no capsule is there. And if there's a good centration, you'll have good no aberrations and so on and so forth. But many of these cases may also have pupil abnormalities, and this is a time you have a chance to correct those pupil abnormalities also. Like this case had a fixed pupil following decentration following a trauma, and therefore we are doing the single pass fourth row pupilloplasty, which has been nicely by Dr. Amar Agrawal and Dr. Priya Narang and group. That is, you pass this 9-oprolin 4 times through the loop that is being pulled out, and then just pull the sutures on each side, and you can do as many pupilloplasties as required. In this case, I thought 2 were sufficient to make a reasonably small pupil. No technique is free from complications. You can have hypotony, cystoid macular edema, decompensation. Like this was one of our early cases where the suture was not under the flap and it led to a severe granuloma which required excision. If you are too anterior in fixating the IOL, pupil capture can occur, which is one of the most common complications. And if your markings are incorrect, if you are not 180 degrees apart or not exactly 2 millimeters on either side, you can have significant IOL tilt also, although the fixation may remain stable. So I think pathogenesis of late dislocation of IOL still is unknown. We still don't know why it's occurring, but it is occurring now much more than what it was earlier as the longevity is increasing. Multidisciplinary approach, I think, is of paramount importance, and I cannot overemphasize the role of vitrectomy and uh, taking in hand the retinal colleague along with you. Thank you so much for your patient listening.